All right, hi everyone. I hope you're having a great day. So congratulations on making it to the last lecture video of the semester. In this video, we're going to be talking about issues that are related to mental health in children and adolescents. So we'll discuss some disorders that often occur in children but not in adults, things like bedwetting, that sort of thing. We'll talk about some disorders that we already know occur in adults but could also occur in children, things like anxiety or mood disorders. And then we'll talk about some disorders that have more of a lifelong course, so things like intellectual disability or ADHD, that sort of thing. So if you have any questions about the content after you watch the video, please let me know. There is not an activity, so we're done with activities at this point. So after you watch this video, you'll have all the information that you need for exam 4 and really for the entire class. So exam 4 is going to have a practice exam and a review video just like exams 1 through 3, and it will cover the material from the last section of the class. It'll be multiple choice, true, false, and matching just like exams 1 through 3. After you take exam 4, the only thing that will be left for you to do for me is the final exam. And I'll be sending out emails and reminders, and of course you can find all this in the syllabus as well. The final exam is going to have some essay questions for you to answer, and it will be set up where you should be able to open it, work on it, save it, come back to it, so there won't be a clock running while you're working on it as long as you turn it in by the due date and time. So let me know if you have any questions. Otherwise, we're going to go ahead and get into our last lecture of the semester.
Alright, so as I said during today's lecture video, we're going to be talking about disorders that are common among children and adolescents. Now, there are several different issues that come up during today's lecture video that are different from some of the other things we've talked about this semester. There are several ways in which psychopathology in childhood is diagnosed differently and treated differently than psychopathology in adulthood, and some of those are going to come up throughout today's lecture. So we know that abnormal functioning can occur at any time in life. Psychological issues are probably most common during emerging adulthood. For each individual class of disorders, there's a range, and some of them may come up a little earlier, some may come up a little later, but oftentimes psychological problems develop during that 18 to 25 emerging adulthood time period. However, we know that issues can come up during childhood, and today we're going to be talking about some disorders that only seem to occur during childhood, but we're also going to talk about some disorders that have adult forms as well, that usually manifest in adults, but that could potentially happen in children. Now, we know that children do go through some difficult experiences. Worry is a common experience. Bedwetting, nightmares, temper tantrum, restlessness. These are just a few examples. And oftentimes when we see these issues in children, they are isolated. Maybe they happen over a short period of time in response to some kind of environmental stress and they go away. So not every child who has these symptoms warrants a diagnosis, but as we're going to talk about throughout today's lecture, sometimes these problems are severe enough that they need to be diagnosed and treated. Now, to kind of get us thinking in the right direction during today's lecture, I have the results, or some of the results, of a survey that was conducted. This sample was individuals aged 8 through 17 and their parents. So the purple bar tells you the percentage of children who are concerned about a particular area, and the kind of greenish yellowish bar is the percentage of parents who think their children are concerned about a certain area. So for example, 17% of the children and adolescents who were surveyed reported worrying about getting into a good college, but only 3% of parents reported thinking that their children were worrying about getting into a good college. So you can see across the board here that parents may not be aware of some of the psychological issues that their child is facing. Now, this is a problem because a parent who is not aware of a problem obviously can't be part of the solution, but it's probably not surprising. We know that during adolescence, especially that difficult time period, Adolescents may not feel like they can trust their parents, may not feel like they can come to their parents with their concerns. And so I think that this is probably a common experience, but an unfortunate experience. A little bit scary as a parent. So we know that adolescence is a difficult period for the vast majority of people. Not too many of us look back on high school and think, hey, that was fun, I'd like to do that again. Some of the things that are going on during adolescence, you have physical and sexual changes, hormonal changes happening as puberty happens. In addition to that, you have a lot of pressure to fit in, to make friendships, to be popular, and you have individuals who are trying to figure out their own identity, trying to figure out who am I and what do I want to be. This is a time when a lot of important decisions are made about do I want to go to college, and what do I want to do in college, what do I want to do with the rest of my life. And so the combination of the environmental stressors with the physical changes and hormonal changes maybe sets the stage for some things like anxiety and depression. Now, when we're talking about a struggle with relationships with other people, bullying is something that we hear about a lot in childhood and adolescence. So bullying is a major issue that I think the vast majority of people would say needs to be addressed more directly. The problem is, I think that we don't know exactly how to address bullying. I think that the parents of bullying victims probably feel kind of hopeless and helpless, like, how do I stop this? And I think as a school system, trying to have a policy here is very difficult because the bullying is not always obvious and it's not always reported. And so that makes this a very complicated issue. About 1/4, 25% of students say that they are bullied on a regular basis, with more than 70 saying they have been bullied at least once. Now, one thing to keep in mind is that you might be wondering about the statistics as far as, okay, well, then what percentage of students are doing the bullying? I think that there would be some overlap here. Probably the individuals who are bullying also may be bullied by someone else. So bullying is obviously an issue. No one who is a victim of bullying says, hey, I enjoy this. Everyone is upset by it. However, the experience seems to be more traumatic for some victims of bullying than others. And so you ask yourself the question, why does bullying impact different people differently? I think it depends a lot on the personality of the individual. It depends on the type of bullying, the severity, the frequency. But I also think it depends in a large part on the protective factors that a person has. So if an individual has experienced bullying, but they have a good, loving, stable home life, consistent parenting, and they have good social relationships, they have friends that they can talk to, if they have some history of success, maybe academic success or success in other areas, I think those individuals are more likely to be resilient. But if a person has additional risk factors, if a person is growing up in a conflict-ridden home with a lot of stress and not a lot of consistency, and if this person feels isolated from pretty much all of their peers, then that individual would probably have a stronger reaction because they have fewer protective factors to kind of fall back on. So when we're talking about disorders of childhood and adolescence, I'll get my mouth going in the right direction in a second. Some of these disorders are disorders we've already talked about as adult disorders as well. So things like depression. We think of depression as being an adult disorder. If I talk about depression, probably the thing that comes to your mind is a woman, right, stereotypically, and our numbers do suggest that women are diagnosed more than men. We think about a woman in her maybe 20s or so, but it is possible that a child could also be diagnosed with depression, as well as some of the anxiety disorders that we discussed. So we are going to talk a little bit about childhood anxiety and mood disorders. But there are also some childhood disorders that we just don't diagnose in adults. So elimination disorders are going to be disorders related to potty training issues. So typically in childhood, someone who has an elimination disorder is someone who has a difficult time controlling their bowels or their bladder, that kind of thing. This usually disappears or substantially lessens by adulthood. And then a third possibility is that there may be a type of disorder that develops during very early childhood, even potentially is present at birth, and then continues on throughout the entire lifespan. So during this lecture video, we're also going to be talking about autism spectrum disorders, intellectual developmental disorder. We're going to talk about ADHD later on as well. All right, so let's start off by talking about some disorders here that may sound a little bit familiar. We've talked about anxiety before, but separation anxiety is a little bit different. Separation anxiety is displayed by roughly 4 to 10% of all children, so relatively common. With separation anxiety, we have a child who is having those anxiety symptoms, so maybe their heart is racing, they're having some worried thoughts, maybe having some changes in their sleep, changes in their eating behaviors, that kind of thing. And the anxiety seems to be related to a loss of an adult, someone that they care about. So a child who has separation anxiety disorder may have panic attacks, may get very upset whenever they're separated from the person that they're concerned about. It could be a parent oftentimes, but it could be another caregiver as well. This often happens because children are afraid that something bad will happen to the adult while they're separated, but it could also be that the child is worried that something bad will happen to himself or herself while they are separated. So we would expect some separation anxiety when a child is spending time away from parents for the first time a child stays overnight away from mom and dad, or the first time a child goes to school, that kind of thing. But with separation anxiety disorder, we're talking about symptoms that are excessive based on the age group, as well as symptoms that last. So we're saying these symptoms have to last 4 or more weeks for children. So this is not the first week of kindergarten nerves that we're talking about here. We're talking about an issue that continues and lingers. And obviously that's going to cause some distress. Now, another issue that can come up during childhood is major depressive disorder. Now, this is relatively rare. We think about 2% of children meet criteria for major depressive disorder, and then about 9% of adolescents. So you do see a substantial increase from childhood to adolescence, and that may be because of hormonal changes, that may be because of social changes, that kind of thing. So you definitely do see this more in adolescents than you do in children. However, it is possible for a very young child, maybe even 5 or 6 years old, to be diagnosed with major depressive disorder. And one issue that becomes very important to this discussion is how are we going to treat major depressive disorder in a 5 or 6 year old, because the cognitive treatments that we do really require a certain level of maturity to be able to figure out which ones of your thoughts are not logical and trying to replace those with thoughts that are more logical. That's not really something that most 5 or 6 year olds would be skilled at. And we also know that adults who have depression often are given medication, and so Prozac, SSRI can be prescribed, FDA approved for children, I believe, the age of 6. Which is kind of startling, and certainly is not my endorsing giving children medication at that age. But it is possible that could happen. So in addition to these rare cases, as many as 20% of adolescents experience at least one depressive episode that may not be severe enough or last long enough to meet criteria for major depressive disorder. So this is something that is definitely happening. Now, depression in young individuals is often triggered by a negative life event. So this may be the time when a person has their first experience with death, for example. Perhaps death of a family member. And it could also be major changes in the home. So this could be something that we would normally consider stressful, like, for example, a divorce. But it could also be something that we often think of as a positive thing, like having a new sibling. So yes, having a new sibling is a positive thing in your life, but anything that causes change can trigger stress, which can also be related to symptoms of depression. Rejection or abuse, this could come from classmates, peers. This could also come from parents and family members. So what does childhood depression look like? It may have some of the same symptoms that you see in depression in older individuals. So that sad mood, loss of pleasure. You see this with a disinterest in toys and games. That's basically anhedonia. The person stops enjoying the things they used to enjoy. But oftentimes childhood depression has more of a medical look to it. So some of those physical symptoms, headaches, stomach pain, changes in sleep, that kind of thing. And so a parent may take a child to the doctor thinking that there's a medical condition going on when perhaps it's more of a psychological issue at heart. So clinical depression is much more common among teenagers than it is among young children, as you saw from those statistics on the previous slide. One thing that is especially scary is the risk of suicidal ideation and attempts. So we know that during that adolescent teenage period, there's a lot of stress, there's a lot of pressure. Also, during that time period, the frontal lobe of your brain that makes decisions, thinks long term, pays attention, is not fully developed. And so because of that, we might start to worry that children and adolescents experiencing symptoms of depression might choose some methods to try to relieve their symptoms. And this could be things like acting out, rebelling. This could be substance use, or even potentially suicidal ideation. This is a concern during this time period, and one that I would imagine most parents have on their radar. Now, one of the things that I should especially mention here is that SSRIs, medications that are prescribed commonly for individuals who have depression, things like Prozac, Paxil, Zoloft. We don't know exactly why, but we do see a substantially increased risk in suicidal ideation when we give these medications to teenagers. And so it's one of those situations where you might be more worried about the treatment than the symptoms. Like the treatment is also associated with suicidal ideation. So very serious issue. If at all possible, therapy would definitely be something you would want to consider before medication. However, if a medication is going to be given, then that individual is going to need some very close supervision. All right, carrying on, talking about mood disorders. Bipolar disorder, which is that combination of symptoms of depression and symptoms of mania, is typically diagnosed in earlier adulthood. But it can happen in children potentially. This is where we have a pretty significant debate. So the number of children being diagnosed with bipolar disorder has increased substantially over the recent years. And so there's some concern here. Whenever you see a diagnosis increasing substantially, you ask yourself, okay, is it truly the case that more individuals are suffering than before? Or is it just that we're getting better at diagnosing, so we're catching some cases we would have missed? Or is there something else going on and we're mislabeling it? So there's concern, and part of the reason that we're concerned about the overdiagnosis of bipolar disorder in children is that we have medications to treat bipolar disorder, and so they're often given to children and maybe given off-label. So the medications might be intended for adults but might be prescribed in children, or sometimes individuals who have bipolar disorder, including children, might be given antipsychotic medication as well. So we're concerned about that. So to try to address this increase in diagnosis, the DSM-5 included a new category. It's called Disruptive Mood Dysregulation Disorder. The hope is that some of the individuals who are being diagnosed with bipolar disorder and then automatically being given adult medications might be more appropriately labeled and treated if they're given this new diagnosis. Now, disruptive mood dysregulation disorder is basically referring to an individual who has outbursts of temper. Typically, we're thinking about temper here. So this may be a child who, instead of having mania, like you would think of mania as an adult, so we're not driving really fast and spending all of our money and staying up all night long. Instead, the child might be having bursts of temper, and that's kind of what mania looks like for them here, or the manic symptoms that we would think about in bipolar disorder, are really just anger issues. So these outbursts must occur at least 3 times per week and have to be present in at least 2 settings. This is important because if the outbursts only happen at school, maybe they're happening because of bullying or because of issues with a teacher. Or if the outbursts only happen at home, then we start to wonder, is there some kind of abuse at home? Is this behavior being reinforced in some way? That kind of thing. But if the problem is happening in multiple settings, then that tells us perhaps that there's something else going on. Now, this diagnosis is intended for individuals between the ages of 6 and 18. This is to try to prevent individuals under the age of 18 from being misdiagnosed with bipolar disorder. Now, after an individual is 18 or older and maybe continues to have some of these symptoms, then at that point you might want to consider assessing for bipolar disorder. Okay? Now, one thing I want to say as I go through and talk about these disorders, about oppositional defiant disorder, conduct disorder, this is something that I hear frequently from individuals outside of the field of psychology, kind of the idea that, well, when a child is misbehaving and you label it as a disorder, I think people are afraid that that's us saying, well, that's just something the child can't help, so we should just let it be. Not necessarily. We're going to be talking about treatments. A child who meets criteria for this disorder, it doesn't mean, oh, well, that child is always going to be a misbehaving child, so we should just look the other way. No, we want an individual to get better. We want to reduce the distress and the dysfunction. So we do have therapies that are intended to try to help these disorders, but sometimes people think that by labeling it this way, we're then letting the kids off the hook, perhaps. And I don't think that should be the case in any situation. All right, oppositional defiant disorder refers to children who are starting to have behavioral issues. Oftentimes, this is where the chain starts. We start off with a young child who meets criteria for oppositional defiant disorder. If we get in there and figure out the source of the problem and treat it, we can stop this before it gets worse in a lot of cases. However, if we do not treat oppositional defiant disorder, then it often progresses to conduct disorder, which is more severe and is going to be addressed in just a second. Children who have oppositional defiant disorder are children who are not obedient to their parents. They argue, and not just parents, but also with really any authority figure. Defiant, angry, irritable. These may be children who purposefully annoy other people. They just enjoy getting under other people's skin. Maybe they try to get other people in trouble, and they enjoy doing this. Now, you will see a lot of children have days where they are like this. For it to be a disorder, it has to be something that's happening over a period of time, and it also has to be something that's not age appropriate. So if you're talking about a 3-year-old who's being annoying, the vast majority of 3-year-olds have their annoying moments. We have to look at how that particular 3-year-old compares to other 3-year-olds, their same age peers. So if a child has oppositional defiant disorder, we're seeing a pattern of defiant behaviors that are not age appropriate. Now, a lot of times we can get in there and we can have some parent-based interventions. We're going to talk about what these might look like in a second when we talk about treatments for conduct disorder. But helping parents be consistent with their structure, being consistent with their rules, reinforcing the good behavior, appropriately punishing the bad behavior. We can stop that in many cases. However, sometimes we shift from an oppositional defiant disorder to a conduct disorder. So the child who has ODD, that oppositional defiant disorder, is a child who just doesn't listen to their parents. They're just not really obedient, and they're annoying and obnoxious. But when you get to conduct disorder, we have crossed a line. We are in a whole other class of problem issues here. These are individuals who violate the rights of others without empathy. They don't feel guilty about what they do, typically. They don't feel sorry for other people, and they engage in some pretty serious behaviors. For example, being aggressive, physically cruel to other people. Now, If this is sounding familiar, good. I hope so. This probably sounds a lot like antisocial personality disorder to you. So in our personality disorder lecture, we talked about adults who had antisocial personality disorder, who did not regard the rights of others, and who did not feel empathy for other people, and engaged oftentimes in dangerous criminal behaviors without regard for others. This should sound familiar. About half of all cases of conduct disorder go on to develop into antisocial personality disorder. So we start off often, this is not always the way it happens, but we could start off with oppositional defiant disorder, and then that gets worse. And then we have conduct disorder. And then if conduct disorder continues unchecked, it can develop into antisocial personality disorder. So very serious, very important that we identify this early and get the individual into treatment as soon as possible. So this typically begins between the ages of 7 and 15. So if you look at some of these symptoms over here, they're very severe, some of the issues that a person might have. So there's a pattern of them violating the rights of other people. Things like bullying, threatening, provoking, fighting, using dangerous weapons, cruelty to people or to animals intentionally, stealing, forcing someone into sexual activity. So rape could be included in this category, or any kind of molestation. Fire setting, destroying other people's property, breaking into houses, cars, buildings, lying, stealing items of value. So several different issues there. Staying out beyond curfew, running away from home, kind of disappearing for several days, truancy from school. So these are the more severe issues that can come up usually during early adolescence is when this starts. So conduct disorder often looks like the very violent, aggressive individual that physically fights other people, physically harms other people. But it's also possible that conduct disorder can involve a heavy dose of relational aggression. So usually we see a gender pattern here where girls are more likely to engage in relational aggression, whereas boys are more likely to engage in physical aggression. And this could be because of modeling, this could be because of hormonal differences. There are many different potential explanations for that. But basically what we mean by relational aggression is that a person tries to go after another person psychologically, emotionally, damaging their relationships rather than physically fighting the other person. So this could be things like slander, rumors. If you guys saw Mean Girls, essentially that entire movie, Mean Girls. Relational aggression. So these are individuals. Now, okay, think back to high school. Most people are involved in this kind of thing once or twice. We're talking about people who have a pattern of this behavior and that do not feel guilty, don't feel shame for their behaviors, and this pattern continues over a long period of time. Now, conduct disorder is very serious. And oftentimes, as I said, it progresses into a full-blown antisocial personality situation. So we need to understand where it comes from. Unfortunately, we found many different potential causes for conduct disorder. There does seem to be some genetic and biological factors. Also, individuals who use drugs. So it could be that the conduct disorder is what led to the drug use. Or it could be that the drug use maybe leads to the symptoms of conduct disorder, but they're correlated. Poverty, traumatic experiences in earlier childhood, exposure to violent peers, as well as issues with parents. So, of course, not every individual who grows up in poverty has conduct disorder. Not every individual who has a difficult relationship with their parents has conduct disorder. But as you look at these symptoms, or these risk factors rather, the more risk factors a person has, the more likely it is that this will happen and the more severe it may be. So things like family conflict, being exposed to marital conflict, domestic violence, that kind of thing. All of these things increase the risk for an individual to develop conduct disorder. Now, if possible, we would like to identify this issue and get the individual into treatment from an early age. This is not always possible. Sometimes symptoms of conduct disorder are overlooked or misunderstood, Or maybe we realize they're there and we try to treat them in ways that are just not very effective. And so it may be that a person does not get into treatment immediately. But treatments are most effective when you start them at an earlier age. This is true for anything. If you have anxiety as an adult, the sooner you get into treatment, the better your outcomes are. So this is pretty universally true. What are we going to do when we're trying to treat individuals who have conduct disorder? We're going to talk about some options. Sociocultural is going to focus on treatments outside of the child. Child-focused treatments obviously are going to include specifically the individual who has the conduct disorder. And then trying to prevent this would obviously be a high priority. So if there's an individual who has conduct disorder, if we're thinking about childhood disorders in general, oftentimes there are family or social issues that need to be addressed. So perhaps a child who has conduct disorder has some strained relationships with their parents where they're not listening, they're not obeying their parents. Maybe the parents are not as involved as they need to be, or maybe the parents just don't know how to engage with the child. So a couple of different options here for family interventions. PCIT, the parent-child interaction therapy, is the idea of having the clinician, the psychologist, kind of coach the parent through some difficult parenting situations. Now, I don't know if this is how it's done with older children. With younger children, they'll often take a child and the parent and put them in a room with some toys, for example, and the psychologist will go into another room and watch what's going on, maybe through a mirror or through a camera, and then the psychologist will kind of coach the parent. The parent will have a little earbud in, and the psychologist will give them some instructions or some advice on how to interact with the child. Probably something similar happens with adolescents. And then parent management training might be something that is done in group settings. It's more economical to do it in a group setting. Group therapy is often more affordable than individual therapy, but it's the idea of bringing in parents who maybe have children with similar issues, and in addition to providing support, also providing some very helpful, concrete, practical tips about how to set rules and what rules are appropriate for certain ages, how to reinforce good behaviors, punish bad behaviors, that kind of thing. So it's basically teaching parents a crash course in behavior modification specific to their needs of their child. We can also have a residential treatment that might be community-based. Maybe if we have issues with several children in a community, which might be the case if there's an issue like poverty or maybe crime or other issues in the community, having the community come together to kind of like it takes a village kind of thing, work together to try to improve the conditions around them, as well as school-based programs. So teachers and principals and other individuals who work with kids need to be trained on appropriate treatments for working with kids with conduct disorder. This is often difficult to do in isolation, though. It's not a situation where we should expect the school system to fix the problem. Obviously, it's going to take the family being involved as well. But we would like to have the school involved. With child-focused treatments, we're talking about working primarily with the child who has conduct disorder. So you can imagine that it would be challenging as a clinician to work with the client. So if you have a 13-year-old with conduct disorder sitting across from you, that person may not want to be there. That child may not want to come to therapy, and they don't have to want to come to therapy. So when a person is under the age of 18, if they're not emancipated from their parents are the ones that are giving consent for treatment, or their guardians are the ones giving consent for treatment. And so the person may be there and they really don't want to be there. And that's difficult for you as a psychologist to try to develop a relationship first, a rapport, to get the person to talk to you at all. Now, a lot of these treatments are going to focus on problem-solving skills. I have actually been trained in the Coping Power program. The basic idea is to help the children and adolescents who are struggling with these issues, help them brainstorm ideas about ways to solve problems they have, and help them to evaluate their possible solutions before they choose which solution is the best one. So, for example, if a student is having problems with a teacher, then the psychologist can say, okay, well, we need to brainstorm. Let's just make a list of all of the possible things you could do. And anything you can think of. Nothing's off the table at this point. And let the child brainstorm and come up. They may say, I want to drop out of school, or I want to fight this teacher, or whatever. Let them list all of the potential ideas, and then help them look at the consequences. Okay, now this is an option for you, but if you dropped out of school, what would happen to your future? That kind of thing. Helping them to see long term. And one of the things that coping power involves is setting goals. So you might set short-term goals, like this is where I want to be in the next week. And then longer-term goals, maybe this is what I want to do when I'm an adult. And so one thing that you find is that you get the best results when you tie what's going on currently with what they want to happen in the future. Like if the person says, well, I want to be a professional athlete. And then you say, okay, well, most professional athletes have to go play for a college before they get drafted. So we got to get you into college. Well, to get you into college, we have to get you through high school. And to get you through high school, we have to get you through middle school. So helping them have goals that are consistent with where they want to be later in life can be helpful. Now, obviously, prevention is ideal if at all possible. We know that there are some cases of conduct disorder that are genetic, and that may be more difficult to prevent, but there are things like, for example, family issues. If there's something we can do as a culture to improve marriage, to improve parenting, to improve communities, to improve social conditions, then perhaps we can at least reduce, if not prevent, some of these cases of conduct disorder. Of course, though, when you're talking about things like trying to improve parenting and improve education and reduce poverty, these are complicated issues that oftentimes don't have a quick solution. The issue is pretty entrenched. And so the little things that we do, though, can add up. So maybe this is something you're passionate about, thinking about ways to help individuals who are in difficult social conditions. All right. Moving on from some of those behavioral disorders, we're talking briefly about elimination disorders. Elimination disorders occur when children repeatedly urinate or pass feces. So we're talking about children who are old enough that potty training should have already taken place, but there's still some potty training issues. Now, it's probably typical for a child to have an occasional accident, even beyond what we would consider potty training years. But when we diagnose a disorder, we're saying that this individual, based on their physical health and based on their age, should not be having as many accidents as they are having. Now, if we're talking about potty training issues, there are two diagnoses that are possible, and a person might be diagnosed with both. So first of all, enuresis, which of the two is more common. Enuresis involves basically urinating on yourself, so bedwetting or wetting of one's clothes. This is oftentimes involuntary, but could occasionally be voluntary as well. Oftentimes occurs at night while a child is asleep. So if you have a child who's sleeping 9 or 10 hours a night, then that's a long period of time to maintain bladder control, especially for young children. And so it may be a situation where a child is just not aware of the signs that they need to get up and go to the bathroom in the middle of the night, and so they might have an accident. It can be triggered by stressful events. It also seems to, in some cases, be genetic. So if a parent had issues with enuresis, then a child is a little bit more likely to have those problems as well. Now, in order to receive this diagnosis, we have to see a pattern of urinary accidents that are happening in a child who is at least 5 years of age. So if the child is under the age of 5, then we would not consider this an appropriate diagnosis. Now, it says that most of these cases correct themselves. Most individuals who have issues with bedwetting oftentimes grow out of this at a certain point. However, it can be very frustrating to the parent and the child while it's still going on. It can impact things like social issues. If you're trying to talk about, do I want to go spend the night somewhere else? Is that okay? It can be embarrassing and difficult for a family. So there are treatments. One of the treatments involves classical conditioning. Without going into any great detail, They sell these at pharmacies, like, I'm pretty sure, I've never bought one, but I'm pretty sure, like CVS, they sell they call it the bell and pad method. So I'm sure if you Googled that, you could find something about it. But basically, it's a product where you put it like right under the mattress or right under the sheets, whatever the case may be. And when the child has an accident, as soon as a drop of urine hits this pad, then it makes a noise, and the noise wakes the child up. The idea being that eventually the child will learn to wake up when they have that need to go to the bathroom instead of waiting until after they already have. And that's something that can take a little bit of time, but seems to be pretty effective. Now, if enuresis happens when a child has a bladder accident, Caprices happens when a child defecates on themselves, passes feces. Basically, we're talking about poop here. Caprices is less common and less well researched, but it can also happen as a result of stress. So it could be a child that seems to be potty trained, and then because of a stressful situation, perhaps the issue comes back up. It is often involuntary and seldom occurs during sleep. So this is something that usually happens as an accident during the day. And you start to wonder, is this maybe like a physical issue? So it's not a bad idea to have a doctor just kind of give a once-over, take a child to the pediatrician to make sure that it's not a health issue that's potentially causing this. But the child may just not be paying attention to the signals from their body, maybe busy, maybe playing and not wanting to stop the activity that they're engaged in. So this has to start after the age of 4, just like with enuresis. And as with all elimination disorders, it's more common in boys than in girls. So a lot of this would focus on goal setting. If we're going to try to treat Caprices, set a goal for going a certain amount of time without having an accident, and then reinforcing that behavior, as well as education, teaching a child what signs to look out for so that they know they need to go to the bathroom, praising and reinforcing a child whenever they do pay attention to those signals and go to the bathroom before the accident happens. All right. So at this point, I have a chart here that has some information for you just to take a look at. It talks about the usual age of identification. So the ones we've been talking about so far are mostly happening at least age 5 and up, although some of the ones we're going to talk about might potentially be recognizable earlier than that. We have prevalence rates, also gender. So we see that females are more likely to have separation anxiety, and we would expect that because we see anxiety disorders more in females. But the remainder of these disorders today, with some of the ones we've already talked about, are more common in males than in females. Part of this may be genetic. So if you look at the chromosomes, a female has XX chromosomes and a male has XY. What that means is that females actually have a little bit more chromosomal matter to work with, so that if there is a chromosomal issue, then the female genetics have a little bit of extra material there to maybe cover up for or lessen the effect of the issue, whereas with a male, that issue may be more severe potentially because of that. So one thing to keep in mind as we talk about more neurological disorders in a second. Also, family history is included here, recovery by adulthood, so you're going to see usually things like separation anxiety as well as elimination disorders usually get better, and then things like conduct disorder, ADHD, learning disorders, sometimes get better, often get better. And then really a lot of the times when we're asking whether we recover, this may have to do with the kind of treatment that a person receives. Okay. So switching gears a little bit, talking now about neurodevelopmental disorders. Neurodevelopmental disorders are a group of disabilities in the functioning of the brain. So we're talking about disorders that have at least strong evidence to suggest that there's a neurological component. So when we talk about things like anxiety and depression, we say, well, there's probably a neurotransmitter issue that's at least part of the problem. But with some of these disorders we're about to talk about, we have really good evidence to suggest that there's a substantial neurological component. These disorders that are more neurological in nature do tend to emerge at birth or during very early childhood. That does not mean they will be diagnosed at birth or early childhood. But looking back after a later diagnosis, a parent might be able to say, yeah, I saw symptoms of that from very early on. And they tend to affect behavior, memory, concentration, ability to learn. So you're going to see a lot of dysfunction associated with some of these disorders. So when we're talking about neurological issues, we're going to start off talking about ADHD. Now, ADHD is one of those disorders where there's a lot of information out there. Some of it is of higher quality than others. One thing I do want to say right off the bat is that the name for ADHD is Attention Deficit Hyperactivity Disorder. And then the DSM would have a specific presentation. So some individuals would have ADHD with the primarily inattentive presentation, where the attention is the issue. Some individuals might have ADHD with the primarily hyperactive presentation, where the hyperactivity is the issue. And then you can also have ADHD with a combined presentation. But ADHD is the term. So sometimes I have met individuals who are very offended when you use the term ADHD. They prefer the term ADD, which is kind of leaving out the hyperactivity. That is not the correct terminology, though, based on the DSM. If a person has attention issues without the hyperactive issues, then the technical diagnosis would be ADHD with a inattentive presentation. So we're going to stick with the technical terminology here. So as we said, children who have ADHD might have issues paying attention, might have issues with that hyperactive impulsivity, or could have issues with both. Now, when you have an individual who has the inattentive type, they're going to look different perhaps than the person who has the hyperactive type. And so the inattentive type might be a little bit less likely to be recognized because you don't always know if the child's not paying attention, whereas you can typically see if the child is being hyperactive. So the number of children being diagnosed might be impacted by that. So the primary symptoms tend to feed into one another. Someone who is hyperactive probably has a difficult time paying attention. Somebody who has a difficult time paying attention is more likely to be a person who fidgets a good bit. But you may have an individual who is primarily inattentive or primarily hyperactive. So if we're looking at individuals who have ADHD, we look at some other correlated outcomes. Children who have ADHD are also at an increased risk for learning or communication problems. So there could be some specific learning disorders here. Poor school performance, social issues with other children because there's something different about the way that child interacts with others because they have ADHD. Misbehavior, it could be that a child who has ADHD has frustrations and difficulty in, like, for example, school settings, and then because of that frustration that builds up might lash out. May also have mood or anxiety problems. This is especially common in females who have ADHD. We see oftentimes a woman who has ADHD, maybe had ADHD as a child, often goes on to develop mood or anxiety problems as well. Now, when we're looking at the diagnostic criteria here, we're going to see that the symptoms have to be present for at least 6 months or more. We're also going to be making sure that they're happening in multiple settings. So if it only happens in one setting, like I said earlier, that could be a parent issue, could be a teacher issue, so multiple settings. And we're also going to look for some of these symptoms at least somewhat being on display before age 12. That does not mean that the individual has to be diagnosed by age 12, but the symptoms are usually there from a much earlier age. Oftentimes this is diagnosed when a child first goes to school, and maybe that's the first time they've been really compared with same-age peers. Now, when you look at these symptoms, they're kind of split into two categories here. So we have the inattentive symptoms that are listed as A. We have the hyperactive symptoms that are listed as B. If a child has at least 6 of the inattentive symptoms and at least 6 of the hyperactive symptoms, then we would say they would have a combined presentation, or they would be having symptoms of both. Where does ADHD come from? Certainly this is a concern because the number of children being diagnosed with ADHD is skyrocketing. I will say that I think part of that comes from we are more aware of it and maybe better at diagnosing it, but I also do think that ADHD is overdiagnosed. I think that I could just stay here forever, and you guys don't want me to do that, so I'm not going to stay here forever. But the idea that perhaps we expect children to do more sitting in a desk than they are biologically prepared for at that age. So it takes a while for the ability to sit quietly and listen to develop. And so perhaps we are expecting more of that kind of behavior from children than we previously have. There are a lot of things I could say here, but I think in some situations we could be creating or worsening these symptoms. But there also are some biological issues to consider. So specific regions of the brain that have been associated with symptoms, dopamine also that has been associated with symptoms, as well as high levels of stress, usually in the family setting, but potentially school stress, peer stress as well. So how is ADHD treated? You guys probably already know this. About 80% of all children and adolescents with ADHD receive treatment. That is a ridiculously high number compared to a lot of the disorders we talk about. Why is it that so many individuals are being treated? Well, I don't want to make it sound like treatment is a bad thing. Treatment is a good thing. But I think that part of this may be one of those, the parent feels like they have to put the child on medication because the teacher wants the child on medication, school situation going on here. There is obviously concern that an individual who has symptoms of ADHD might fall behind, and so treatment is needed. The most common treatment, though, would be a drug therapy. Now, the drugs that are typically given to children and adolescents for ADHD are stimulant medications. So it gives the example here of Ritalin, Adderall could be another example, and there are others. Stimulant drugs that do seem to help a child or even an adult pay attention. Some of the difficulties associated with that, though, is that these medications, first of all, have side effects. I have had individuals taking these medications tell me that they feel like zombies when they're on this medication. That's their words, not mine. Feeling like they're sluggish, feeling like they don't have as much mental sharpness, that kind of thing. But also, sometimes these symptoms can manifest themselves as growth issues. So children who are taking stimulant medications may not have growth spurts like typical children do. So that's why oftentimes a drug holiday is suggested. So over the summer, over Christmas break, whenever we can, have a child stop taking the medication to try to give their growth a chance to catch up. So there are obviously side effects to consider. It is also possible that an individual might receive behavioral therapy or a combination of drug therapy and behavioral therapy. So there are some behavioral things that you can do. Reinforcing appropriate behavior. A lot of the behavioral things would also be making accommodations for the person. So just things like a quiet place to take tests, or maybe some extra time to take tests, or if it's a child who's hyperactive, having an opportunity to get out of their desk for a certain amount of time every day, that kind of thing. So as I said, many individuals with ADHD are treated with stimulant drugs. Now that sounds ironic. I understand that giving someone who is hyperactive a stimulant drug, but it seems to work well for individuals who have ADHD as far as treating their symptoms. Stimulant drugs also are given for things like sleep disorders. If a person has narcolepsy, then that can be treated with a stimulant drug. So there are many different things that stimulant drugs can do. It is estimated that 2.2 million children in the U.S. take Ritalin or some other stimulant drug for ADHD. So that's about 3% of the school population. And I would imagine that these numbers will probably continue to rise. Now, as you may have already been able to pick up, I have some concerns about the issues, the side effects that come along with medicating young children, specifically with stimulant medications. Obviously, ADHD, though, can be a serious issue that can impact a person's school performance, and so parents have a lot of difficult decisions to make in this area. As far as behavioral therapies go, as I said, parents can use operant conditioning to try to change behavior, but you need to set appropriate goals. If you tell a child who has ADHD that they can have ice cream if they sit in their desk all day, they're not going to be able to be successful at that. So you need to set goals like sitting in your desk for 5 minutes, maybe as much as the person can do in the beginning, and then reinforcing that. So you can do things like that in combination with drug therapy or alone. But it is, I'm sure, a difficult situation for a teacher, because a teacher would have several different children with several different potential special needs in the classroom. And so it is really hard to have time to do that in addition to just the basic responsibilities of teaching as well. So definitely a tricky issue. When we're talking about research on multicultural factors in ADHD, we see that minority children, African American, Hispanic American children, they are a little bit less likely to be assessed for ADHD than white children. Maybe less likely to receive a diagnosis and less likely to receive treatment. So this is an issue where there is certainly a lot of work to be done. I think the thought here is that part of the issue with getting an assessment and getting a diagnosis and getting appropriate behavioral treatment from the school, part of that issue comes from financial concerns. So if there is a school district that does not have the resources to be able to provide that assessment or to provide the treatment that would need to come along with the results of that assessment, then that individual may be less likely to receive the help that he or she needs. So because they may be less likely to receive those interventions, then we might see more long-term issues as a result of that, because the ADHD that is there might not be recognized and might not be diagnosed. So as it says, this could be tied to economic factors, and as well as just kind of general awareness here and making sure that our school systems do a better job. One thing to note is that public schools are required to provide this assessment, diagnosis, and treatment as best they can, although how well they're able to do that does depend on the funding, the amount of money that they have. Other types of school systems, like for example a private school, they would not be required by the government to provide that assessment, and so they may or may not do that. All right, so kind of moving on from ADHD here, autism spectrum disorder and intellectual developmental disorder are a couple of different disorders that oftentimes are recognized early on, but are longer term disorders that may or may not improve as an individual gets older. So we're going to start off by talking about autism spectrum disorder. Now, autism spectrum disorder is the DSM-5 terminology here. So previously we might have autistic disorder, Asperger's syndrome, other potential diagnoses, but in DSM-5 they're all lumped together into what is called an autism spectrum disorder, and then they are labeled as mild, moderate, or severe in the nature of the symptoms. So when you're looking for something like autism, there are really 3 hallmark symptoms here. So first of all, you usually see some impaired social interactions. And as I said, that severity is on a spectrum here. Some individuals may have more severe social issues or less severe. In addition to that, they often have communication problems, as well as some fixations or some strange behaviors that might look almost OCD-like, some basically obsessions. So autism spectrum disorder is one that we hear a lot about because individuals are doing quite a bit of research on why the rates of autism spectrum disorder are increasing. And so before I get into anything else on this slide, I do want to briefly address the autism spectrum vaccine debate. My advice for you would be to do your own research on that and to research both sides before you come to a decision about that issue. What I will say is that a lot of the early research linking autism spectrum symptoms and vaccines was falsified or was not done well. And so I would encourage you to look critically into this issue before you make a decision one way or the other. So kind of getting back to the symptoms here, you see the criteria. So there's usually some social issues, some communication issues, and there may also be some like restricted fixated interest. This is what I'm talking about with kind of an OCD obsessive-like nature. An individual who maybe has some very specific things that they enjoy doing, very few things that they enjoy doing, and get very upset if they are interrupted in that. And oftentimes there can be some sensory issues as well. So children who have autism spectrum disorder may be especially bothered by loud noises, for example, or certain smells, or lighting can also be an issue here. Now, these symptoms have to appear early on, but they may not be diagnosed early on. So symptoms usually appear before the age of 3, but that doesn't mean that there's a diagnosis. It means that once the individual receives a diagnosis, looking back, we typically see the symptoms started by age 3. Now, around 80% of all cases appear in boys. As I said, there is that potential chromosomal issue that could be causing that, so the XY in males versus the XX in females. And then there may be some other things as well. There may be some, there are a lot of different potential causes for autism that still need to be researched. So as many as 90% of children continue to have significant disability into adulthood. So this is dysfunction here basically. So individuals who have autism spectrum disorder may have difficulty in self-care depending on the severity, may have difficulty in developing relationships, may have difficulty in school, for example, or in a workplace setting at an older age. Also, the lack of responsiveness and social reciprocity makes it difficult for them perhaps to develop relationships with friends, or romantic relationships may also even make, parent-child relationships difficult. So it's difficult as a parent to have a young child that does not respond or communicate to you in the way that you expect. One thing that we see is oftentimes language and communication problems. And this can take a number of different forms, but it also is on a range of severity. So there may be some individuals who have autism spectrum disorder who have very few symptoms related to communication, and those may be mostly social in nature. And yet there may be some individuals who have severe symptoms almost on a nonverbal end of the spectrum. So this is, really a wide variety of dysfunction here. Now, as I said, the DSM-5 has included all of those previous separately diagnosed disorders together in this one autism spectrum disorder category. So basically what they're saying is that Asperger's disorder or Asperger's syndrome, according to the writers of the DSM-5, is not thought of as a different disorder. It's actually thought of as a milder version of autism spectrum disorder. So one thing that we see is that individuals who have Asperger's disorder or previously would have been diagnosed with Asperger's disorder often do not have some of the other problems that can be associated, like, for example, intellectual issues. So if maybe half of individuals who have autism have intellectual issues, those individuals that were previously diagnosed as Asperger's disorder might just have mostly the social issues without the intellectual academic issues that you can see with autism. But they have decided that there's not enough evidence that these are separate issues, and so they've combined them together. So someone who previously met criteria for Asperger's disorder would now be diagnosed likely with autism spectrum disorder mild. So, as I said, there are many theories about where autism comes from. Some of these are more psychological in nature, cultural in nature, biological in nature. Some individuals would say that this is perhaps a cognitive issue, of a way that a person thinks about themselves and thinks about their environment. So there's the suggestion here that individuals might fail to develop a theory of mind, which is an awareness that other people base their behaviors on their own beliefs and intentions. Basically, what we're saying here is that individuals who have autism spectrum symptoms might have a difficult time seeing things from another person's perspective, might have a difficult time thinking about things a different way, maybe a rigid way of thinking about things because it's difficult for them to think about things from a different perspective. Now, what I want to say here when we're talking about issues, especially when we're talking about autism spectrum disorder, is that oftentimes people want to try to tell themselves that this won't happen to me and that this won't happen to my family. So people might start to blame parents or other caregivers for a child having autism spectrum symptoms. And I want to say, first of all, that the research doesn't really bear that out. So this theory that family dysfunction and stress is what causes autism spectrum symptoms, first of all, research does not support that theory. Second of all, that is not helpful for a parent who is struggling. If you see a family where a child has autism spectrum disorder and a parent is having a lot of stress and there's a lot of difficulty going on there, it may not be that the stress caused the autism spectrum symptoms. It may be that the autism spectrum symptoms caused the stress. It would be very difficult to be a parent of a child with autism spectrum disorder. So instead of judging, perhaps we should look for ways to provide support, ways to maybe reach out and take care of the caregivers here instead of blaming them. Oftentimes, research focuses on a biological cause for autism spectrum disorder, but the difficulty is that we don't know exactly what the cause is. We have a lot of research out there. There does seem to be a genetic component because the prevalence rates are higher among siblings than they are in the general population. So if you have a sibling with an autism spectrum disorder, you're more likely to also have an autism spectrum disorder. And it's highest among identical twins. So this has come up several times with several different disorders. Identical twins sharing basically the same DNA. If there is a genetic component, you would expect that identical twins would have similar outcomes, and this is the case for many disorders, including autism spectrum disorder. Now, is it possible that there are specific biological issues that contribute, perhaps some specific brain areas that might have problems? It is possible. Some of the research has focused on the cerebellum, which is located at the back, at the base of the brain. And the cerebellum may be an area that needs more research here with its relationship to autism spectrum disorder. How do we treat individuals who are having these symptoms? Well, it depends on the severity of the symptom, first of all, and how much the dysfunction, how much it's causing dysfunction and distress in that person's life and in their family members' lives. We can work with individuals who have autism spectrum disorder to help them adapt to their environment. So with training, individuals who have autism spectrum disorder can, depending on the severity, go on to have, very independent lives, to work and to have relationships. There isn't what we would call a cure or a treatment that tends to at least reduce the symptoms substantially. The symptoms, depending on the severity, we might be treated by cognitive behavioral therapy, so reinforcing good communication, reinforcing positive social behaviors, that kind of thing, as well as parent training and also taking care of the parents. So parents can very easily get burnt out and stressed out when dealing with a child who has autism spectrum disorder. So making sure that the parents are taking care of themselves so that they can take care of the child as well. Integration into a community, so perhaps if there's a work training program or mentorship program, something to get the individual involved with social relationships. In addition, psychotropic drugs, so there may be some medications that can help. It talks about vitamins here. There are a lot of different diets and things like that. There's probably not a lot of research on that, but there may be some individuals who respond well to certain diets, and so that may be something to look into if you're personally interested. As I said, parent training is important when it comes to families who have a child with autism spectrum disorder. Oftentimes it's very practical. It's that parent management training where we teach behavior modification techniques to parents so that they can provide them at home. So let's talk about the specific problem behaviors we want to decrease, or those specific healthy behaviors we want to increase, and let's have a specific plan for your child to help us reach our goals. So individual therapy as well as maybe group therapy, support groups are helpful. Making sure that we're reinforcing parents for self-care. If you're only ever withdrawing from your psychological bank account and never depositing, then at a certain point you're going to go psychologically bankrupt. So having the parents focusing on healthy eating and sleeping habits and making sure that the parents have someone to talk to also helps them take better care of their child. Alright, so moving on to intellectual developmental disorder. Now, this is one potential term for this particular disorder. The other terminology that you might hear currently would be intellectual disability. So what we're talking about here is what would previously have been referred to as mental retardation in earlier forms of the DSM. But with each new edition of the DSM, in addition to changing the criteria that we have for particular disorders, we sometimes also change the names of disorders, particularly if there's been some kind of stigma associated with the previous name. So intellectual disability or an intellectual developmental disorder refers to an individual whose intelligence is below what we would expect for their age, and they're also going to have some problems with adaptive functioning. So what we're saying here is that a person's intelligent quotient, which is a score on an IQ test, which we'll talk more about in just a second, must be 70 or lower, roughly in that range. And in addition to that, the person also has to have some difficulty with adaptive functioning. Basically what I mean by that is a person who's having difficulty functioning in everyday environments. So it could be that a person is, because of intellectual issues, having trouble at school, having trouble with self-care, having trouble at work, having trouble with relationships. So we would look for a combination of those two things. The reason that we have to have them both is because some individuals might score very poorly on an IQ test for whatever reason. Maybe there's a different issue going on, or maybe a person is just not a good test taker or not putting forth enough effort, that kind of thing. But if a person has a low IQ score and yet they are still fully functional in their everyday life, we would not diagnose an intellectual disability. So we need both of those criteria, as well as having the symptoms appear before age 18. So typically, intellectual developmental disorder is something that we see and we recognize in younger children. The more severe the symptoms, usually the earlier you catch it. But if a person has had typical functioning, typical intelligence, and then after the age of 18 starts to have some cognitive deficits here, then it would not make sense for that to be an intellectual disability. In that situation, we'd be looking for maybe a traumatic brain injury or substance use, that kind of thing. Now, the first criteria here is saying that a person's intelligence is below what we would expect for their age. So how do we measure intelligence? I think we talked about this earlier in the semester when we talked about assessment, but we can give something called an intelligence test. The idea behind an intelligence test is to measure a person's potential to learn. So we're not necessarily asking specific memorization kinds of questions. Instead, we're asking about a person's overall spatial reasoning or overall verbal comprehension, that kind of thing. So there are many different intelligence tests that are out there. It says these tests consist of a variety of questions. So some individuals may score poorly in a certain area. Maybe, for example, a person's memory is a little bit behind what we would expect. However, because there are several different areas on the test, a person would have to have poor performance in several of those areas before they would actually have a score low enough to meet criteria for an intellectual disability. So you're going to look to the overall test score, which is impacted by all the different sub-test areas, That overall test score, or IQ, is what we would use to help us with our diagnosis. So we talked, I think, earlier in the semester about the Wechsler test, about how they measure working memory, perceptual reasoning, verbal comprehension, and processing speed. And so you would have a score for each one of those 4 things, and your overall score would be impacted by your score in each one of those 4 areas. Now, technically the criteria say 70 or below is when you would consider diagnosing someone with an intellectual disability. Having said that, though, there's a reason why we have to have a cutoff, because if we don't have a cutoff, if we just generally say IQ is low, then we might start to wonder, well, is an 80 low? 79? So we need a cutoff because it helps with our research, it helps with our diagnosis. Having said that, though, if a person is still having functional deficits and their IQ is hovering around 70, they might still get a diagnosis. So our tests are not perfect. So if a person has a 71 or a 72 on an IQ test, but they're still having some adaptive functioning issues, then you might consider going ahead with that diagnosis. But for the purpose of our research and for the purpose of this class, 70 is our cutoff. However, as I said, having an IQ score below 70 with 100 being average, by the way, just to give you guys something to think about as you're looking at these ranges, 100 would be considered average, so we're saying 30 points below average. We can't just use that cutoff because some individuals might score poorly on an IQ test for other reasons but might still be able to function. So in addition to an IQ test, we would also give some kind of adaptive functioning test. Now, the Vineland is one that has been around for quite some time. It does show some reliability and validity. It's a bit of an older test, but pretty helpful. There are several different adaptive functioning tests. Basically, we're just asking, is this a person who can take care of his or herself at a level that is appropriate for their age? So for young children, you might look for some basic social behaviors, some basic self-care. Is the child potty trained? Can this child brush his or her teeth? Or, can they take turns playing a game with someone else? That kind of thing. But then as a person gets older, there would be some other additional criteria that you would expect. As we get older, there are more responsibilities that we have. So you would take into account the person's intelligence score. You would take into account the person's daily functioning, which you might not get just from a test, but also from an interview and also from observations. And in addition to that, you might take into account the person's unique situation. So, for example, if a child is not doing certain behaviors, it's possible that it's not because the child is not capable, but just because the parents haven't asked the child to do those behaviors. So taking all of that information into account, you would then make a decision about whether or not a person meets criteria. Now, when we're talking about a person who has intellectual disability, what we are not saying is that this is a person who cannot learn. Unfortunately, that's what a lot of people think when they hear about an individual who has an intellectual disability. And it's dangerous to think that way. So people very often meet the expectations that you have for them. And so if you're a parent or a teacher of a child with an intellectual disability, if you don't expect much from that child, you probably will not get much from that child. But of course, if you have expectations that are too high, the child will become anxious and frustrated, so that's obviously not good either. But we need to have appropriate expectations. An individual who has an intellectual disability can still learn. The biggest difference is that they learn more slowly. So they will meet their milestones likely, but they'll meet those milestones a little bit later. So for example, with communication, children typically start saying their first words around their first birthday, and they start making sounds and kind of putting together sentences as they get closer to their second birthday. A child who has an intellectual disability may still be able to do that, but will do it at a later time. So it just takes a little bit longer. They may also have difficulty with attention. So oftentimes a diagnosis of an intellectual disability is comorbid with an ADHD diagnosis. May also have memory issues, planning issues, as I said, and language. So when we're talking about symptoms for an intellectual developmental disorder or intellectual disability, just like many other things, there is a spectrum here. And on the more severe end of the spectrum, individuals might be institutionalized. If we feel like a person needs more help and care that they can get in their home and school environment, they could potentially be institutionalized. But you would expect that individuals who were institutionalized would be the ones who would have the more severe symptoms. So let's start off on the mild end of the spectrum. So the vast majority of people who meet criteria for an intellectual disability fall into a category of a mild intellectual disability. So this is about 80 to 85%. Now in this range you have an IQ score between 50 and 70. So average is 100. A lot of people who have mild intellectual disability have scores somewhere in the 60s or maybe getting close to 70. So what we actually see is that intellectual performance oftentimes improves with age. So if you continue to follow and give intelligence tests to a person, their IQ score may increase as they get older. And part of that may be that a person finds what works for them in their environment. So, all children learn things a little bit differently. But if it's a child that has an intellectual disability, it may take a while for parents and teachers to find what works for that child when it comes to school, when it comes to reading, when it comes to motivating them. But as individuals get older, they may learn what works for them, and that may actually help boost their score on an intelligence test. So where does a mild intellectual disability come from? It is possible that it could be genetic. However, a lot of the milder cases here seem to have more cultural, societal, psychological issues, like, for example, unstimulating environments, inadequate parent-child interactions, insufficient early learning experiences. So this is why it is important to read to children. It's important to expose children to more educational things, because as a child gets older, if they don't have those experiences during those early years, it's harder for them to catch up. Children at a very young age are sponges, but you can't get anything out of a sponge if you haven't soaked it in water, right? So you have to fill the child's mind with high quality information, because that's how children learn. When they're little, they're like sponges and they memorize everything. And then as they get older, it's more of trying to understand the things they've already memorized and learn them more deeply. So those early years are very, very important. So if you have kids, you're around kids, read to children. Very, very important. It is possible that a genetic issue might be at play here. Thinking about something like intelligence, which is obviously a complicated issue, and we don't have an answer that fits every particular situation, but I once had a supervisor explain it to me that it's like a rubber band. So your rubber band is what genetics give you as far as your intelligence goes. And a rubber band can either stretch a little bit, don't stretch it at all, or it can stretch very far. So the idea is that you're given a range by your genetics of potential intelligence. And then where you fall in that range depends on your experiences. So some people might have a rubber band where they're the best, maybe the maximum that they can do is a 90 IQ. But if they have stimulating environments, they'll end up closer to that 90 IQ versus being on the lower end. There may be some people who have a rubber band where their intelligence could be substantially higher. You could be 120 or 130 on an intelligence test. But if the person doesn't have a stimulating environment, they'll never meet that full potential. So it's a combination of both the genetics that you receive as well as the environment that you are in. Now, when we talk about more moderate, severe, and profound cases, these are not always, but very often caused by biological genetic issues. So about 10% of people who would meet criteria for an intellectual disability have moderate intellectual disability, which would be a score on an IQ test around 35 to 49. Now, these individuals typically can learn, but they're going to learn, as we said, a little bit more slowly. They're going to need more practice. They're going to need more hands-on instruction. But they can learn some basic things, self-care, potentially vocational training. So these individuals may be able to have a job and with a lot of patience and a lot of practice can learn to be successful in a workplace, as long as they have structure and as long as they have, people there helping them. Now, if we move a little bit further down the spectrum, about 3 to 4% of individuals who would meet criteria for intellectual disability would have severe intellectual disability. This is an IQ score between 20 and 34. These are individuals, as you might imagine, as the symptoms become more severe, that would have a difficult time with basic tasks even. And so these are individuals that would need to have constant supervision, whether that be from a family member or potentially if an individual is in an institution. The person would need to have supervision, but could learn some self-care tasks and some simple tasks with a lot of practice. Beyond that, only about 1 to 2% of individuals who have intellectual disability fall into the profound category here, which is an IQ score below 20. It's very difficult to get an IQ score that low. As it says on the slides here, these individuals can potentially learn basic skills, but they're going to need a very structured environment. They're going to need a lot of patience and one-on-one tutoring, and appropriate expectations would be very important here. So there are several different potential causes for an intellectual disability, but as we said, the more severe and profound and moderate cases as well oftentimes have a genetic cause that may also include some physical handicaps or some other health problems that are associated with that. Sometimes individuals have things like Down syndrome, which also can have some like heart-related issues and other things associated with it as well. So the primary causes, as I've been saying, of the more moderate, severe, and profound are biological. So individuals who might have the more mild intellectual disability may have it because of problems in the environment, and there may be something specifically that a person could do to adjust that environment to have better results. But as the symptoms become more severe, it's more likely that it is a genetic issue. But having said that, just because a person has a genetic issue, once again, you have a rubber band. You can either stretch it or not stretch it. A person has a range of potential here, and where they fall in that range would depend on their environment. So genetic causes, as I mentioned, like for example, Down syndrome, but there are several other genetic disorders. And in addition to genetic disorders, I think we briefly talked about fetal alcohol syndrome during the drug use lecture. So fetal alcohol syndrome is the most common preventable cause of intellectual disability. So obviously it's very important for a mother to refrain from using substances during pregnancy. Always check with the doctor before you use a substance during pregnancy of any kind. So there are also other things that can happen before, during, or after birth that could potentially impact intellectual development. Some issues can come with blood flow and oxygen to the brain during birth. Sometimes there's a traumatic birth experience. There may be some kind of bleeding issue or some difficulty delivering the baby, and in those situations you can potentially see some harm that can impact a person's intellectual abilities. So the cause aside, even if it's a biological, genetic, medical cause perhaps, the quality of life that a person attains is still very much influenced by their environment. So if you're a parent or a caregiver or family member or teacher that is working with an individual who has an intellectual disability, as I said, you need to have appropriate expectations and provide a lot of reinforcement when the person makes any kind of strides whatsoever. Make sure to reinforce that. Trying to provide, if we have to, comfortable and stimulating residences. So this could be more of an institutional kind of setting, but with or without the institutional setting, we want to think about social opportunities, which can be challenging for individuals who have an intellectual disability, but crucial. Economic opportunities as the individual gets older. Is there some kind of job training some kinds of jobs where an individual can maybe work with a mentor, have someone there that has experience helping people with intellectual disability, and a proper education, which is huge. Obviously, a proper education is important for everyone, but it's especially complicated when you talk about a person who has an intellectual disability. Historically, based on our research, these individuals do best when they are diagnosed at an early age and they get into early intervention programs. So knowing that a child is likely to learn things differently and may need more reinforcement, may need more time, it is important to have as much one-on-one tutoring and help as possible. And that's where we run into an issue in a school setting. So there's a debate over whether children should be placed into a special education class or whether children should be mainstreamed, which would be placing them into a class based on their age. So obviously there are arguments on both sides. If you take children and put them in a special education setting, they may be able to get more individualized help. If you're a teacher in a mainstream classroom and if you have 25 or 30 students that all have a range of abilities, it would be very difficult to give a particular student the one-on-one time that he or she might need to be successful. Having said that, though, there is a concern about placing children in special education classes. First of all, do you create a stereotype or a self-fulfilling prophecy where the teachers, because this child is in special education, don't expect the child to do well? Or the child might internalize that and say, well, I'm in special education, so I'm not a smart person, so I can't do well. So once you create those low expectations, then the individual may not be able to achieve their best potential. So there's also the concern, though, that if you take children and put them into the regular classroom for the purpose of trying to maintain self-esteem, then in addition to academic issues, you may also have social issues if other children haven't been taught how to interact with someone who is different and who might have some disability there. And so I think that would be a learning experience for everyone involved. There's no particular right answer here. I think it depends from situation to situation, but a lot of this has to do with, is the teacher prepared? Does the teacher know enough about intellectual disability and the particular student to be able to help that student be successful? All right, in addition to more academic interventions, sometimes individuals who have an intellectual disability also might need some therapy. So cognitive behavioral therapy, and when we're talking about someone who has intellectual disability, depending on the severity of the symptoms, it might be better to go with a more behavioral therapy because cognitive therapy might require a certain level of intellectual functioning that just might not be there with a person who has intellectual disability. But a person who is diagnosed with these learning difficulties might also have things like anxiety issues or depression issues or behavior problems. As I said, ADHD is often comorbid with intellectual disability. So about 30% of individuals who have an intellectual disability would also meet criteria for another diagnosis. And so individual therapy or group therapy can be helpful here. Sometimes psychotropic medications might be prescribed to try to help an individual that has emotional or behavioral problems. But you also have to keep in mind that there are side effects associated with that as well. All right, so how can we increase opportunities for individuals who have intellectual disability? As the individual gets older, it is important to provide as much independence as possible where the person can still be successful. So you wouldn't want to give a level of independence that sets the person up for failure, expecting them to do things that they cannot do. But at the same time, it is important to give them as much freedom as possible, and part of that comes with perhaps holding a job. Now, as you can imagine, it is difficult for a person who has an intellectual disability perhaps to find these educational opportunities because they do usually have to involve additional training, additional mentors, additional support, and that may not always be available. So this is an area where there's certainly work to be done, and we need additional programs, because I think it is especially helpful for individuals who have intellectual disability. Good for them to have the independence and to boost their self-esteem and to provide some financial security for them. So if at all possible, it would be great if we could have more opportunities like this. Alright, so that is actually the end of our last lecture video for the semester. So please let me know if you have any questions about anything we talked about during today's lecture video. I enjoyed this semester, and I hope I have the chance to teach you guys again.